tonight. So good evening. I'm going to get started. My name is Abigail Donnelly. I'm a member of Project Lyme's Emerging Leaders Board. I'm going to be your moderator for tonight. So before we dive into the question segment of our event, I'm just going to briefly introduce our four incredible panelists to give you some background on where they're all coming from. So Jen Thayer is a former senior advisor to the US government and to the UN. She has 35 years of experience across 45 countries. She's worked with a variety of nonprofits and multinational corporations, and she was recently involved in shaping the World Health Organization's ICD-11 codes to recognize life-threatening complications from Lyme disease. Dr. Richard Horowitz is a founding member of ILADS. He's a prior member of the Federal Tick-Borne Disease Working Group and the New York State Lyme and Tick-Borne Disease Working Group. He's also the medical director of the Hudson Valley Healing Arts Center, where he's treated over 13,000 chronic Lyme patients, advancing the frontier of Lyme care. He's presently working on an NIH-approved trial that centers around dapsone combination therapy and has a book forthcoming next year. Jen Barrett earned her JD from Seattle University School of Law, where she wrote a journal article titled, "It's About Lyme: Why Congress Must Enact Medical Insurance Coverage Laws for Lyme Disease Patients Now." In addition to offering a rich history of the legal context that shapes modern healthcare laws and the lives of tick-borne illness patients, Jen's article outlined what potential federal legislation to improve healthcare accessibility could look like, and she'll be sharing some of these innovative ideas tonight. Jen Russell is the founder and executive director of Illinois Lyme Association, which focuses on providing support, awareness, and education to individuals and families affected by Lyme disease throughout Illinois. Her advocacy has resulted in a Medical Provider Protection Act, the creation of a Lyme disease task force, state-regulated insurance coverage for tick-borne diseases, a partnership with the Illinois Department of Public Health and Natural Resources, and more. Okay, so I'd like to just begin with a quote from a subcommittee to the 2020 Federal Tick-Borne Disease Working Group to kind of set the stage. They write, quote, "The combination of legal risks and inability to participate in an insurance network have resulted in fewer clinicians willing to diagnose and treat Lyme disease. This has created an extreme access to care issue for patients who cannot find treating physicians and do not have insurance coverage. 50% of participants report that their clinicians do not accept insurance coverage. 26 report that they cannot find a clinician who treats persistent Lyme disease, and 18% report that they do not use antibiotics because their insurance will not cover them." So, Jen B, I'm going to begin by turning to you for us to go back to the beginning and just talk a little bit about how we got here. So can you begin by telling us the distinction between ILADS treatment guidelines and IDSA treatment guidelines and why this distinction matters?
Yeah, of course. I just want to start out with saying that the information I'm providing on this webinar is for educational purposes only and should not be taken as legal advice in any regards. I'm not currently working as an attorney. So let's go over those differences between the IDSA and the ILADS guidelines. So it all comes down to whether persistent symptoms are the result of persistent infection. So the Infectious Diseases Society of America believes that persistent, recurring, nonspecific symptoms like fatigue, pain, and cognitive impairment in the absence of arthritis, meningitis, and neuropathy are what they call post-treatment Lyme disease syndrome. They state that there are no high-quality studies showing persistence, no clinical or laboratory proof of persistence, and that extended use of antibiotics is harmful for patients, and some of these patients might not be suffering from Lyme disease. On the other hand, the International Lyme and Associated Diseases Society, they state that persistent or chronic Lyme disease is when symptoms last for 6 months or more, and that is a sign of active and ongoing infection. They have an emphasis on clinical judgment and individual assessment for each patient. They recommend continuing treatment if symptoms persist after initial treatment. And they want providers to inform patients about the risks and benefits of extended treatment, which and not giving that treatment may result in significant morbidity or permitting a serious systemic infection to progress. So important information about these guidelines is that guidelines are used by providers to determine how to treat patients. They're also used by hospitals and government agencies as well as insurance companies. So if an insurance company is going to follow the IDSA guideline, which overall recommends less treatment, they may be more apt to deny more claims.
Awesome, thank you. Just a little bit of clarification on the difference between surveillance criteria and diagnostic criteria, and why these specific terms are important and matter. And returning again, first to Gen B and then to Dr. H.
Oh, um, so I think Dr. H, if you could go over the difference, and then I'll talk about the significance.
Yes, of
So,
course.
yeah.
So first of all, I want to thank everyone here and thank Project Lyme for putting this on. I think it's an important webinar for people to understand the difficulties because being in the trenches now for 41 years doing this, I have a lot of personal experience of why doctors don't want to use insurance companies to do this. But essentially, the difference between the surveillance and diagnostic criteria is surveillance criteria used by health departments to epidemiologically screen large populations of patients to make sure that they actually have a disease and that they're dealing with true positives and not false positives. Whereas what we're dealing with clinicians is it's a clinical diagnosis. Now, the CDC does say on their website that Lyme is a clinical diagnosis. We know that you do not have to use the two-tiered criteria or the modified two-tiered criteria, which also are good for early Lyme. That is not the only way that you make the diagnosis. And so, for example, we've published years ago in 2017 a validated Lyme questionnaire in 1,600 people in the International Journal of General Medicine. If you score over 63 on that questionnaire, there's a very high chance, over 2 standard deviations, you have Lyme. And migratory pain, which is the hallmark of Lyme, there's only 7 diseases in medicine that cause it. So as a clinician, if I see somebody with a chronic fatiguing, musculoskeletal, neuropsychiatric illness, which can be caused by a lot of things, but someone says to me, I have migratory joint pain, migratory muscle pain, or migratory nerve pain, tingling, numbness, burning, stabbing, which is essentially neuropathy, Lyme is the only thing that causes that. So when we're dealing with that, and then you get, at this point now, thank God, an FDA-approved immunoblot. IGeneX just got FDA approved for their immunoblots for Lyme and recently Bartonella in New York. If I see any Lyme-specific band on an immunoblot, 23 OSP-C, 31 OSP-A, 34 OSP-B, 39, 8393. If you've got migratory pain and you've ruled out other diseases and have any one of those bands on an immunoblot, you have borreliosis. And in our practice, we're also finding, of course, Bartonella and Babesia and a whole host of things. So it's a difference between the surveillance criteria that they're only going to use two-tiered criteria. They're not going to use the same clinical criteria that I would use as a clinician.
Right. And then to add to that, the CDC lists on their website that surveillance criteria, their kind of higher criteria should not be used by healthcare providers in making a clinical diagnosis. And just to see how it affects numbers, there were 89,000 cases reported to the CDC in 2023, whereas the CDC estimates that it's closer to 476,000 people who are getting it a year. So you can see the huge difference that creates.
So just to clarify for the more colloquial of us out there, surveillance criteria, it's a much harder standard, higher standard to meet than diagnostic criteria. And this issue is when surveillance criteria is misused as diagnostic criteria by insurers. And this is why so many claims are denied. All right, so we're gonna move on slightly and talk a little bit more about the CDC, which recognizes what's called post-treatment Lyme disease. And Jen, you were talking about this a little bit earlier, but not persistent Lyme disease or chronic Lyme disease. And so often when we talk about insurance law, it comes down to these nuances of language that take on importance that isn't easy to explain or to recognize for those of us who don't have a background in the subject. So Jenna, can you talk about why this terminology difference matters specifically to our discussion?
Well, specifically, post-treatment Lyme disease syndrome, or PTLDS, and similar terminologies, anything that says post-treatment, anything, because there are a number of terms that say post-treatment with regards to Lyme, is basically used to deny coverage for extended treatment of an underlying bacterial infection. And what happens with insurance companies, they have coordinated with medical guidance, mostly through what's called UpToDate. And UpToDate is used by over 200 institutions globally, over 100 nations, thousands of physicians across the globe. And they are told that people who have been treated with the standard course of IDSA short-term antibiotic treatment are now all to be classified as post-treatment and therefore do not have any more treatment coverage or need for treatment. So that's the basic, the way in which it's explained. And in fact, insurance companies have restricted the the options for extended treatment even further in the last couple of years. Prior to the establishment, following the establishment of the Affordable Care Act, Lyme was seen as a chronic condition with open-ended treatment options. That was in 2012, and that has been curtailed further and further and further with the adoption of this term, post-treatment Lyme disease syndrome.
So it's pretty significant, just to reiterate, that the CDC uses the terminology post-treatment Lyme disease or post-treatment syndrome instead of persistent or chronic Lyme disease. And this was something that the Federal Tick-Borne Diseases Working Group, which you're going to hear me reference a lot, talked about. They advocated or recommended that Congress include both ILADS and IDSA guidelines and both ILADS and IDSA language on government websites, including CDC websites. So what they're advocating for is that the CDC not just use the language of post-treatment Lyme disease, but also use the language of persistent or chronic Lyme disease, so we can avoid the kind of coverage of treatment restrictions that Jenna was just talking about. So pivoting towards the legal landscape, Jen B, can you please provide us with a brief overview of some of the legal cases that have brought us to where we are today? Specifically,
Yep.
maybe talking about Richard Blumenthal investigation when he was Connecticut Attorney General, and what else you see as particularly relevant.
Great. So the first one I'm going to talk about is an Empire Blue Cross Blue Shield lawsuit with, again, well, patients were suing Empire Blue Cross Blue Shield in the late 90s, early 2000s. It was basically about IV antibiotics and whether treatment was required after their initial treatment with IV antibiotics. The outcome of the case isn't quite as important as the fact that we got to see kind of behind the curtain of where insurance companies kind of started tightening regulations and rules. So in the early 1990s, Lyme disease was extremely expensive for insurance companies. It was right up there with cancer and transplant and diabetes as like, the top five most expensive illnesses. And that was mostly because of the use of IV Rocephin, which is an IV antibiotic that's relatively expensive. And so when insurance companies were looking to cut costs, they started to target Lyme disease because they believed that the symptoms were vague. There was an overdiagnosis they felt at the time, and they thought that it was difficult to cure. And so they tightened restrictions for IV requirements and they required surveillance criteria, which we just spoke about. They specifically required a recollection of tick exposure, so actually remembers a tick bite or a manifestation of the bite on the skin, like a rash, a positive ELISA, as well as a positive Western blot, and the exclusion of other common illnesses that could explain clinical findings. Now, they did this at a time when they did know that some people who tested negative for Lyme disease actually had the illness. And their thoughts behind that was that those people would appeal and eventually get care. But the problem is that it takes time to go through an appeal process. And they also knew that some people just won't appeal. Um, and so that was, kind of a major thing to understand and see what's going on in the background. The other thing is that the contract between the insurance company and the patients agreed to cover treatment that was considered medically necessary, but not treatment that was deemed not medically necessary. And what falls into not medically necessary is experimental treatment. And so experimental treatment is not proven to benefit or not generally recognized by the medical community as effective or proper treatment. And so when they started writing policies that claimed that IV antibiotics over 30 days had no medical or scientific basis, it allowed insurance companies to start denying care. And actually, you will still see this in today's policies. If you go into policies, they'll say, after 30 days of IV antibiotics, it becomes experimental, and then it's a case of whether or not they decide to cover it.
Thank you. There's just two things that I want to highlight for our audience out of what you just said. The first is that what Jen just described insurers requiring, specifically the use of surveillance criteria as a diagnostic, directly contradicts the CDC's recommendation for the use of its own surveillance criteria. So the CDC expressly acknowledges that surveillance criteria is surveillance, not diagnostic criteria. And what Jen was just talking about was insurers misusing surveillance criteria as diagnostic criteria, and mandating that surveillance criteria be used as diagnostic criteria in order to cover certain treatments. The second is the experimental treatment issue that Jen brought up. So what she essentially described is a situation where we don't have, because Lyme disease, though it's been around for a minute, started really emerging in the 90s and 2000s and began to be recognized as a public health crisis. And Dr. Horowitz is going to talk more about this later, but because this disease emerged within the last 50 years to public consciousness, we don't have avenues of accepted treatment. All treatment at some point towards the beginning of a pandemic are going to be experimental. So to require treatment to not be experimental for a disease that does not yet have treatments that are effective or recommended leaves patients in a lurch and leaves patients without access to care.
And a lot of things are effective for one person and not effective for another person. So it's kind of like we're missing a huge, study that can show that that's effective for a large amount of people. And then I'll just feed into the 2008 Richard Blumenthal investigation. He was the Attorney General for Connecticut at the time. Now he's a senator for Connecticut. It was an investigation to see if the IDSA had an antitrust monopoly, basically like prevents competition in the market, in the medical market for Lyme disease. And so his office did an investigation of the 2006 guidelines, and the findings, and this is a quote from him, was that the IDSA's 2006 Lyme disease guideline panel undercuts its credibility by allowing individuals with financial interests in drug companies, Lyme disease diagnostic tests, patents, and consulting arrangements with insurance companies exclude divergent medical evidence and opinion. And so what happened from there was that the
Yes.
Attorney General's office required the IDSA to create a review panel of the guidelines to determine whether they needed to be revised. Well, the panel was filled with IDSA doctors, and they recommended no change to the guidelines. And so that's kind of where we are. Kind of things just kept going in that direction, and insurance companies didn't, change their policies based on that.
Unsurprising, but disappointing. And in terms of IDSA, guidelines causing difficulty, I'd like to again quote from the Federal Tick-Borne Diseases Working Group. They write, the IDSA is widely recognized as the preeminent infectious disease specialty society in the United States, publishes 2 of the 3 most influential infectious disease journals. Its members exert strong influence on peer review for medical journals by serving as peer reviewers and editors. Because of the IDSA guidelines are frequently used, clinicians who treat outside them can become a target. Some lose their licenses, and others have restrictions placed upon them or have their reputations sullied through medical board action. And you're going to hear testimony to that effect a little bit later in our program. So we're going to leave the legal landscape behind for a brief moment, and we're going to turn towards Jen Russell, who is going to provide us with an overview of where things stand politically at the state level. And she's specifically going to talk about different kinds of state level legislation that exist to address the lack of care and just provide us with some background on her work. So Jen, I turn to you.
Thank you, Sabi. So this really gets to the heart of what we're doing here in Illinois and where we're heading. So let me start with a name, Lauren Russell. So Lauren is my daughter, and her life was turned upside down by Lyme disease. She went years without a proper diagnosis or care, caught in a system that wasn't equipped to recognize or treat tick-borne illness. But Lauren's story didn't end in silence. It became the catalyst that led us to create ILA, the Illinois Lyme Association, a 501c3 nonprofit. Our mission is to fight for change, awareness, and better outcomes for patients across Illinois. And change did happen. And here are some of the things that we've accomplished. Because of Lauren's story, Illinois passed Lauren's Law. This law protects providers who treat chronic Lyme outside the CDC recommended guidelines without fear of losing their license. We have already seen this law work. As an example, one provider was contacted by a state agency. They sent the agency a copy of the law, and that issue was resolved. So additionally, the law establishes a task force within the Illinois Department of Public Health, which includes members of the Lyme disease community, researchers, and many legislators from both sides of the aisle. The task force focuses on tick-borne disease education. The work of ILA has also sparked a change in statewide tick tracking and testing efforts. So before 2018, Illinois had no official tick surveillance program, but because of ILA's efforts, the Illinois Department of Public Health began the first active tick surveillance program for the state. And we now know that the deer ticks are testing in Illinois at 40% positive. So ILA also fills a gap by funding the state's only passive tick surveillance research program in partnership with the University of Illinois. In 2019, we helped pass House Bill 889, and this law requires any Illinois state-regulated insurance plan and Medicaid to cover long-term antibiotic treatments, doctor visits, and testing for tick-borne diseases. Additionally, it mandates coverage for FDA-approved experimental drugs and off-label uses in treating tick-borne diseases. The law allows patients to submit claims for out-of-network care. We have heard from many who have already received reimbursement checks, some in the tens of thousands of dollars, which I'm sure people on this call today know that that is a life-changing amount for many families. This law has been a great starting point, and it gives many patients in Illinois a tool they didn't have before. ILA, along with the tireless efforts of state legislators like Representative Dan Swanson, built the legislative momentum that we have today. So now we have many champions in Springfield, and tick-borne disease legislation has been a bipartisan effort and is passing unanimously. Today, ILA works directly with the Illinois Department of Public Health and the Illinois Department of Natural Resources to raise public awareness. We've co-created educational materials. We co-hosted Illinois' first ever statewide tick-borne disease medical conference with nearly 800 providers registered. We just launched a statewide trail sign and park poster campaign to reach our outdoor communities where prevention matters most. So if you are asking, what can I do? Like Lauren, you can share your story. In our experience, that is what moves legislators, not statistics, but faces and families. And that's how we've made progress, and that's how we'll continue to make change on behalf of Lyme patients in Illinois.
Thank you, Jen. And we're going to talk a little bit more about what everybody listening can do later in the program. So if you're listening and you're thinking, I really want to get involved, but I don't know where to start, we've got you, don't worry. So out of what Jen just said, I just want to highlight that she briefly mentioned three different kinds of legislation with three different goals. The first is data collection. So what she was talking about, what she called tick surveillance. The second is protection of medical providers. So when they provide care legislation that aims to make sure that they are negatively impacted. And the third kind of legislation that she mentioned is mandatory coverage of specific kinds of care for patients. So there are patient-focused bills, there are provider-focused bills, and there are bills that focus on gathering data. Gen B is going to provide us with a little bit of a comparison between different states and what different states are doing differently at this point in time.
Great. Yes. So insurance coverage first began with Connecticut in 2000, where there was a law that required initial IV and oral antibiotics to be covered. And then it covered long-term treatment if recommended by infectious disease, rheumatologist, or neurologist. The problem here is that some of the specialists or some of the doctors treating Lyme disease don't fall into those categories. And so that was kind of a limitation. It was a great start, but a little bit of a limitation. A few years later, Rhode Island came along with their own law. It didn't require a type of provider to have that extended antibiotics. They just required evaluation of patient symptoms, diagnostic test results, and the reason for treatment. And they said that treatment should not be denied solely because it's unproven, experimental, or investigational in nature. So this was a huge step in the right direction. And then we had Massachusetts who came along and they changed that and to an or. So it became patient's symptoms or diagnostic tests or responsive to treatment. And that's really expensive because, as we've mentioned, the diagnostic test isn't actually that accurate. And so removing that requirement for a positive test opened that ability for those patients to get insurance coverage. And the other thing that was really important about Massachusetts is that the state did an evaluation of the cost to insurance companies prior to the bill being passed. And with their research, they found that premiums that someone was going to pay for insurance coverage would increase by a negligible amount or 11 cents a month. And so that's like extremely low, right, to provide coverage for the state of Massachusetts people. So that was very interesting. New Hampshire, Minnesota, West Virginia, and Illinois followed along after that. So.
Thank you. We're going to expand a little bit from, we've been talking about the state level. We're going to pivot now towards the federal level. And here we're going to start with Dr. H. Maybe you want to tell us a little bit about how you came to be on a federal working group and provide us with some federal background about where things are today.
Yeah, so I served on the first round of the tick-borne disease working group. It was around 2017, 2018. I was one of 7 members of the public chosen from across the U.S. to work with the CDC, the NIH, the FDA, and the Department of Defense. And truthfully, it was, I would say it's enlightening when we got together in Washington and we met. We had very open conversations. It was very respectful. But unfortunately, I will tell you, and also having served on as co-chair of the co-infection committee, nothing really ever happened from it. So in other words, the committee started about a year late. I was working, I'm not exaggerating, 40 hours a week for free for the federal government for that first year because we had to get in something to Congress at the end of that year. And I never saw really truthfully anything come from it. And when I was working as co-chair, everyone fought me about putting Bartonella. We each got to choose which co-infections we put on. So Alan, who was working with the DOD, had his choices, and there was rickettsiosis, et cetera, anaplasmosis, babesia. I had to, argue that, listen, we really need Bartonella because it's showing up, and it was included. But again, if you go in this day and age and you ask some of the federal government level, is Bartonella an issue with chronic Lyme disease? I don't think anyone's really going to know. So it was a lot of work, and I don't really see that much came out of it, almost because whatever that happens at the federal level, I'm not sure the congressional and Senate members read the reports. I'm not sure it made a difference at the state level. I personally didn't see anything come from it. And similarly, when I worked on the New York State Department of Health Tick-Borne Working Group for several years, we did a report and the report kind of disappeared. Nobody knows where the report went. We don't know if insurance companies buried it. We have no idea where all the work we did went. So there's politics that are still going on. I've reached out to RFK Jr. to try and meet with him about what HHS is doing for Lyme at this point in time. So far, I've not had any luck contacting his childhood friend, Michael, but I'm still trying to get in touch with him because supposedly he's had Lyme, his family has had it, and I don't think he realizes how bad the epidemic is in the United States. If we're really trying to improve care in the United States for chronic illness, you can't ignore Lyme and tick-borne diseases as well as all the toxins that are getting into people. So it was a nice experience working at the federal level, but I don't think much came from it.
Thank you for sharing. So the Federal Tick-Borne Diseases Working Group that Dr. H is talking about was started because of the passage of the 21st Century Cures Act, for the folks who are political nerds like me and who are going to want to Google things afterwards. And because Dr. H also talked about his experience on the New York State Working Group, including how the final report was kind of buried and it's not publicly available online or findable, I want to just highlight State Bill in New York S4571. It passed, but it was vetoed by then Governor Cuomo. And the bill, quote, found that health insurance companies have denied services related to necessary medical treatment. And what the bill would have done was direct the Department of Financial Services, in consultation with the Commissioner of Health, to study and report upon insurance coverage for the treatment of Lyme disease. So this would have been the data backing up the need for state level legislation. And that study was never completed because of that veto, in keeping with the pattern that Dr. H just described. Jenna, can you add anything to kind of the federal insurance context that we're currently discussing?
Yes, absolutely. And in general, just about federal working groups. In my time working for the federal government, I was on 7 different federal working groups. And it's pretty quick to determine which ones are there with work in mind and objectives, and others which are there to appease outside groups. And they are set up for political reasons, and they are set up for hardworking reasons. And I would say, as I observed the committee membership and how the whole thing was legislated and put together for the tick-borne disease working group, I had concerns from the beginning that it was actually going to be a functional change agent in terms of meeting the goals of the patient needs. And to compare it, less than half of the participants on the tick-borne disease working group represented non-government officials, less than half. Whereas the AIDS federal working group, 80% of the participants represent patients and caregivers and doctors who treat patients with AIDS and HIV. So I'm just telling you, there's a big difference in terms of when you are going through this process and you're voting on decisions that will be represented in Congress and represented in federal policy, and you have a vote that is already spun to not really make change versus one that will represent patients, that makes a big difference. So I'm giving you this perspective. The other thing I wanted to say is that this tick-borne disease working group was one of many, many federal working groups over time, held in various agencies and at various levels with Congress, going back to the early 1990s, whereby the Department of Defense and Congress and Senate and CDC and NIH all pledged to make progress in certain areas, and you can see it in the congressional testimony. And yet, when the general accounting offices and the inspector generals did reviews on these promises and pledges, you can see that there were really no advances taking place since the 1990s. And in large part, it's because there were never any hard metrics assigned to creating a change. And so if you have pretty policy language that is not tied to a direct and hard outcome, then the money does not have to be spent in a way that makes a change. And so this is one of the ways in which the lack of progress has been allowed to continue in this area of tick-borne illness. Does
Thank
that
you.
make sense, everybody, in terms of metrics and spending budgets? Yeah. You
What
don't you
I'm
don't get anywhere if you don't have a hard metric, you know?
Absolutely. What I'm hearing is that there were good intentions behind the 21st Century Cures Act, but in effect, it was not very effective. And I'd also just like to highlight that the notion that nobody is reading the reports. If you do read the reports, if you do take the time to read the reports, the subcommittee reports were recently pulled from the CDC website, but if you use the Wayback Machine through Internet Archive, you can access them, and the main reports are still available. The reports themselves are what I would describe as alarming. I mean, the quote extreme access to care issue, that's language that's being published on a government website. It should be taken seriously. So I think for patients, providers, representatives who are listening, who it can be very overwhelming to educate yourself on this topic. I think those reports are a really great place to start. And I think that the more eyes that we can get on them, the better, despite the fact that they're not being tied to metrics. They're still a really necessary foundation, and they include a lot of really pertinent information, though they are flawed. So we're going to expand even more broadly now, and we're going to look internationally for just a minute. So Jenna, can you talk us through your involvement with the World Health Organization, and just provide us with a brief overview of where things stand politically at the international level?
Sure. First, I'll speak about the ICD codes. The ICD codes are the international codes for diseases that are used by 194 member states that are part of the World Health Organization, including the United States. So most of the world uses these ICD codes. And every decade or so, they get updated to reflect the latest science and advancement in medicine and knowledge. And so they are in the center, directly in the center of all of our insurance claims and coverage. Every time you go to a doctor's office, they will assign an ICD code if they're using insurance or they're reporting to their state on medical issues or nationally on nationally notifiable diseases. An ICD code is assigned. Now, without an ICD code, a disease is not recognized. Without an ICD code, a complication of a disease is not recognized. So for more than 25 years, there were only 3 codes recognized for Lyme disease, and they included arthritis, meningitis, and polyneuropathy. After 25 years, an international group that I helped to form, we worked with the World Health Organization and the special rapporteurs for health, human rights, and the defenders of human rights, and documented over 15 human rights violations across 11 international and regional treaties that are signed by all the members of the United Nations, showing that there had been extreme discrimination against this patient population, as well as their caretakers, as well as the parents of people who are trying to take care of their children, as well as the providers, the healthcare providers. And these were all documented across multiple nations, put into 2 reports, and presented to 2 special rapporteurs and the World Health Organization. Now, we already had the science proving persistent infection and proving multiple complications from Lyme disease over time, but the science alone was not going to move the needle because the science has been ignored for decades. The science has been completely ignored and dismissed for decades. However, when we put it within the rubric of human rights, it got their attention, and we were able to expand the codes to more than 16 new codes, including recognizing demyelination of the nervous system from Lyme disease, dementia caused by Lyme disease, other disorders, various eye complications, disseminated Lyme, unspecified, which covers a whole range of symptoms and problems, Lyme carditis, and then dementia. Oh, I mentioned that dementia, and also even congenital Lyme can be now coded in the new ICD-11. So this was a huge expansion of recognizing the science, but we had to use human rights to get the science recognized because they kept ignoring the science prior to that. So where are we with the use of these codes? Well, as I said, the United States will be using these codes. However, they are dragging behind many other countries. As of 2025, more than 45 nations have adopted these codes. However, Canada, Netherlands, Norway, Finland, and Thailand are at the forefront, and they're already being used for public health reporting and clinical reimbursements and insurance reimbursements, whether you're on national insurance or private insurance. And they're reporting that the new codes are very efficient and they're better for getting into the nuance of various diseases. So with regards to Lyme, this is very hopeful because that means that all of these nations, Netherlands, Norway, Finland, we all know that there's Lyme disease in those countries. So they can already be using these codes. However, these codes have been validated. So that means anyone who wants to make use of these codes as an advocacy tool and an educational tool, I recommend they do so. In the United States, we are lagging behind. We are now piloting this, and right now we are in the midst of Medicare, Medicaid, and the American Medical Association updating the reimbursement guidelines. So we're in a huge political battle in the United States as to what will be reimbursed, and that's where all of this friction comes in, and where the science and the human rights gets shunted by other political interests and financial interests. And then in 27, 28, they will be adopted over time. And then nationwide implementation begins in 2029, 2030. So we're really slow to do this. And the reason we're very slow in the US is because we have a privatized healthcare system. And there's big money in it. Unlike other nations that have national healthcare systems where this becomes a more seamless thing, we are fighting through various political and economic interest groups trying to get who will get what for what, recognizing what disease, what code, what procedure, and what treatment.
Thank you.
So that's where we are in the United States and where we are globally on the ICD codes. However, the science was validated. So to give you an example, in the Netherlands, a person was told that they would not be given any more treatment coverage for Lyme disease. The person was very sick. They were told they had the option to have euthanasia. So they're not sick enough to get treatment, but they're sick enough to be euthanized. And this has happened multiple times also in Canada, and there are more and more reports of this happening in various countries. So there's still a resistance to providing covered care for this disease. However, people can be so sick they will be offered euthanasia.
Thank you. I
So
think we're going to have to just move on for time's sake, but
sorry.
I appreciate the detail. No, thank you. We're going to stay in the vein of the scientific side of things for a little while and diagnostics. So, Dr. H, I'm
Yeah.
going to turn to you. In your clinical experience, what are some treatments that are covered by insurance, and what treatments, especially those that you might consider necessary as a doctor, are not covered?
So, let me just start off with my insurance experience early on, which is why I'm not in HMOs and insurance companies, because I didn't get a chance to talk about this, is going back very shortly after I came up to the Hudson Valley, New York, I started discovering babesiosis. And I was the first doctor to discover it in the lower Hudson Valley. I reported it to the health department. I reported it to the HMOs and some of the insurance companies. They came into my office. I had them look at a lot of charts, 30, 40, 50, 60 charts. I actually looked back. I had hundreds of positive PCRs for Babesia microti. This goes back like 30 years. They told me point blank there was no babesiosis in the Hudson Valley. I was using too much of their funds. I spent $70,000 on Mepron and Zithromax prescriptions for a disease that didn't exist. I got thrown out of the HMO and at the time another insurance company, which I will not mention, and had to go before medical boards. And over the last 40 years of my life, I probably spent over $250,000 of legal fees, having to continuously go to medical boards. Each time they let me go, but every time I had to call my lawyer and go before a medical board, it's a stressful circumstance and it costs a lot of money. Fast forward. So years ago, I was treating with IV antibiotics because it was effective and I was, getting some success. The insurance companies were not always covering it because of the guidelines. Well, fast forward now we're talking about just 2 years ago, I published the last study on dapsone combination therapy. I have developed a 9-week oral generic protocol that is highly effective for Lyme and even for Bartonella. The scientific literature is showing that these are biofilm persister bacteria, and I've applied for an NIH R34 grant. I worked with a company for about 4 months. My 501(c)(3, the MSIDS Research Foundation, paid about $32,000 to hire this company so I could get an R34 NIH grant submitted. It's been moved to a scientific committee, and we're looking at a multi-center, placebo-controlled, randomized trial for dapsone combination therapy for the treatment of Lyme, and also looking at what I'll call MSIDS variables, meaning the other things that are keeping people sick, which cause inflammation, and that is Babesia, Bartonella, mold, heavy metals, leaky gut, microbiome issues, sleep disorders, vitamin mineral deficiencies, hormonal dysregulation. So all of these things keep people sick, and that's what the randomized trial will look at. But again, regarding coverage,
I think Dr. H might.
are the treatments covered right now? They are. The oral treatments are being covered. But it's going to be covered worldwide after a multi-center trial.
Got it. Well, thank you for sharing. That's really exciting news about your trial. It's definitely giving folks something to look forward to in what has been a bit of a gloomy conversation, I think, so far. So, Dr. H, you started diving into this. I'm going to first turn to Jenna, and then I'm going to let you finish this one off. Very simply, why aren't patients getting the care that they need?
So I think the reason patients aren't getting care is the doctors are afraid to treat. They've got insurance companies on one shoulder, they've got medical boards on the other. You can pass all the laws you want at the state level. Doctors know that they are being called before medical boards on a regular basis. I have colleagues that have had to stop practicing medicine. And when you've gone through med school and you've had the expense and the time to do this and you have a family, to put your life and license on the line is not an easy thing for doctors to do. Most of the doctors who treat chronic Lyme, they have had it, their families have had it, their children have had it. If you ask most of the treating doctors out there, they've had personal experience with themselves or their families. It's not to say they're not compassionate and they don't want to help patients, but I think they're scared, and rightly so. And although the state laws have changed and we have made progress, I think, in New York State, yes, Governor Cuomo did try protecting us, and it's been better, by the way, since that got passed. But doctors are scared. And I think that's why you're not seeing a lot of doctors out there willing to treat.
The sentence "doctors are scared to treat patients of X disease," I think, is quite scary to anybody who hears a medical provider say that. That should never be the case. Jenna, do you have anything you'd like to add on this one?
Yeah, I mean, basically, what Dr. H just described is happening to hundreds of thousands of medical practitioners across the globe because it's the harassment was well documented. These are human rights violations against human rights defenders, people who are trying to treat some of the most vulnerable patients in the world are being attacked. And they are being attacked by special interest groups that are mostly based on financial incentives. And what we're dealing with is not just the fact that doctors are afraid to attack, but I mean afraid to treat for possible loss of license and livelihood, but we're also dealing with a huge globally orchestrated disinformation campaign about Lyme disease that even counters the World Health Organization ICD codes. And the authors of the up to date clinical guidelines that are used by 2 million clinicians across the globe, healthcare professionals in 190 countries, more than 700 health hospitals and healthcare systems in 25 countries, and has 20,000 individual up-to-date subscribers in 139 countries. These guidelines are written by IDSA members, and the editor is Alan Steer. So nothing in up-to-date reflects any of the recent science, the understanding, or the treatment options that we all know can bring about improved quality of life. So, when people are being told this, you go into a doctor's office and they look at their computer, you give them the symptoms, up to date drops down what you should do. And this is what people are following. They're not necessarily going to medical guidelines that they see at the CDC website or even the IDSA. They're doing to this short form of cliff notes on what to do. And so they are being misdirected and misguided. And there was a recent publication on the medical gaslighting of patients, and it involved a survey that went to multiple countries. And it found that patients, even when they had a tick attachment and a bullseye rash, they were being denied treatment. It
Thank
was
you.
very common.
Yeah, we're going to push forward a little bit, but
Yeah.
the notion of just more education, both from a medical standpoint, the need for these diseases to be covered in medical school is definitely something that we should pull out of that answer.
Mhm.
Dr. H, I'm going to go back to you and I'm going to push ahead a little bit here for the sake of time. Can you talk about some of the data barriers and data gaps that are critical to fill in terms of the current literature and the future research that you feel is critical to fund?
Sure. I think Lorraine Johnson has done a great job, and my Lyme data, she has filled in some of those gaps with data because I forget if it's 18,000 people, 19,000, whatever she has. She's done a great job of gathering data in large populations, talking about denial of care, which co-infections are showing up, right? What treatments are working. So, I mean, she has helped really do a great job filling in part of that gap. But everyone knows in medicine, the gold standard is a randomized multi-center placebo-controlled trial. And Speaking of Alan Steer, just so you all know, I reached out to Alan Steer to see if he would be interested in participating in my randomized trial. He let me know he was semi-retired. He sent me over to Paul Auwater. I contacted Paul Auwater, who is reviewing our R34 grant. I invited him and Hopkins to be part of the trial. Mount Sinai has agreed, as has Charles Chu from the University of California, San Francisco, and University of Arizona look like they're also interested. So I have several, big universities, and I've invited Harvard as well as Hopkins to be part of it if they want to be. Once the trial is done, and I would not do this trial if I was not sure about the results. Once this trial is done, a lot of the legal problems, a lot of the treatment problems, the coverage problems, it should theoretically go away because that is the gold standard of care, is a randomized multi-center placebo trial. And that's essentially what we're doing. And honestly, if it wasn't for Hopkins and Stanford and Eva Shoppe's group from the University of New Haven discovering about the biofilm persistiforms of Borrelia and Bartonella, all the work I did and what I've published, and I've published 9 articles on dapsone combination therapy. We have from Tulane an animal model showing it cures Lyme, where Doxy doesn't, where it wipes out the infection. We have a culture study showing that as you add antibiotics in culture, you're affecting the biofilm persistiforms. And we have about 400 patients in the retrospective studies over these 9 studies I've published. But 400 patients, culture studies, and animal studies is still not enough, right? We still need a randomized multi-center and placebo-controlled trial because of the politics and what this is.
Got it. Thank you. And what Dr. H just mentioned, My Lyme Data, that's a voluntary patient registry. So for the patients that are listening, one thing that we can all do to contribute is to log on to My Lyme Data and add our stories to the testimony and contribute to helping that data grow. Jen R., can you talk a little bit about the state in Illinois, how surveillance criteria is hindering your effort, and what data you guys specifically are missing that would be helpful to further your efforts?
Yep. So one of the data barriers for the Illinois specifically, or for the states, is the narrow reporting criteria used to confirm cases of Lyme disease. So it significantly undercounts the number of people truly impacted. So the Council of State and Territorial Epidemiologists revised its case definition. So now in high incidence areas, the new criteria allows reporting of cases based solely on laboratory evidence, while low incident areas like Illinois still require the clinical information in addition to the laboratory data. So this makes it extremely difficult for states like Illinois to ever be considered endemic. So as a result, many real cases are excluded, and our state appears to have far fewer Lyme cases than it actually does. So for example, in 2023, Illinois only reported 327 confirmed cases, but private healthcare claims data shows that over 6,000 Illinois patients sought care for Lyme disease for the same year. That gap directly impacts our opportunity for federal funding and limits access to public health resources. So this gap definitely needs to be addressed. Additionally, every state urgently needs accessibility to funding for tick surveillance, and not just those on the East Coast. So states like Illinois are trying to get ahead of the problem. But without that financial support, it's hard to track the true spread of the disease. So without better data, states like Illinois will continue to be overlooked and patients will continue to fall through the cracks.
Thank you. And I think the ending note on preventative funding is so important. And the notion that preventative funding is often and preventative efforts are often the most critical of efforts because they end up saving a lot of money in the long run. As patients know, treatment is way, way more expensive than taking preventative measures. So we're going to go back to Jen R. For just a minute. Can you speak to an ongoing legislative or advocacy-based effort in your state that you're working on right now that aims to improve access to critical care and just kind of fix some of these barriers that you've been talking about this evening?
So absolutely. So advocacy and legislative work is ongoing in Illinois, with the Illinois Lyme Association leading the charge to better care and resources for those living with Lyme and other tick-borne illnesses. So we worked closely with the Illinois Department of Public Health to close gaps in provider education. A major milestone that I mentioned earlier was the statewide medical conference where we co-hosted with IDPH. Healthcare providers heard from experts like Dr. Scott Cummins on alpha-gal and Dr. Brian Fallon on mental health and Lyme, for example. Training like this helps ensure patients are diagnosed earlier, reducing risk and of reducing years of misdiagnosis or inadequate care. So we're also working to remove barriers to testing access. So ILA partnered with a local health department to offer direct access to tick-borne disease testing, allowing anyone in the state to participate. So patients do not need to see a doctor first. So we worked with a lab that accepted insurance, which reduced out-of-pocket costs and made testing more accessible. So I think Dr. H touched on this earlier. So on an innovation front, the FDA approved AccuDart test from IGeneX now allows patients to collect samples from home, especially valuable for people in rural areas without access to a Lyme literate medical provider. Nonprofits like ILA are also bridging gaps to help patients in care. And so we help families find Lyme literate providers. Often just guiding someone through the first steps can dramatically change health outcomes and reduce risk. Affording care is definitely a challenge. There are some grant programs that exist. So a few are like the Limelight Foundation, supporting patients 25 and under. The Live Lyme Foundation helps support children and adults under 21. The Lyme Treatment Foundation, the Lyme TAP resources, or excuse me, Lyme TAP reimbursed for out-of-pocket lab testing. So there's also other ways to reduce medication costs. So GoodRx and Optum Perks provide discount codes. Many pharmaceutical companies also offer copay assistant programs, and Mark Cuban's Cost Plus drugs offer transparent pricing with no middleman, often at a fraction of retail cost. Also, Lyme Warrior also has a lot of product referrals at a discount. So while there is no one-size-fits-all fix, these combined efforts from partnerships and innovation to direct support are making care more accessible, affordable, and patient-centered.
Awesome, thank you. I know we're coming up on the hour, folks, but I want to end by turning to Gen B, and I want to just talk a little bit about what a federal bill that aims to relieve patient burden and fix so many of the issues that we've talked about tonight. What does that look like?
Great. Yeah, so state legislation is fantastic. It's definitely necessary. It needs to continue. Federal legislation would help fill in some gaps. There are some insurance plans, if it's employee paid, sometimes um, that doesn't, they don't have to follow state law. So a federal law would require that coverage. And also, there's states like I live in Oregon, and there's a perceived thought that there's not Lyme out here, which there is. And so it's harder for progress to be made at the state level in areas such as that. And so a federal law would cover everyone regardless of where they live in the United States. And we can make it a win for everyone, right? So if insurance pays for extensive treatment at the beginning, it's more likely that the patient will have positive outcomes later on. It'll cost the government less because people will be healthy and they'll be able to work and they won't require additional assistance from the government. And, as I've mentioned, it's not as expensive as it used to be. Not as many people are using IV Rocephin. As Dr. Horowitz mentioned, there's different treatments out there now. And it's a huge win, obviously, for patients, better quality of life. And so I created draft legislation that Savvy's nicely going to include in a packet for you guys that goes off of, you know, making sure that medication, laboratory testing, and doctor visits are covered, as those seem to be the largest drivers of cost. And then the second part of the bill would require tracking of insurance companies on whose claims are being submitted and whether those claims are being denied. It's very interesting because Maine actually has this law in place. So they're able to see how many people are claiming insurance for Lyme and how many of those treatments are being denied, etc. So modifying that to fit in a federal law, those two combinations, I think, could really help with access to care.
Thank you so much. So that is unfortunately all the time that we have for tonight, but I want to just take a minute to thank all of our really incredible panelists for participating. Your time is so valuable, and from a patient's perspective, I so appreciate you all helping to educate us so we can be better advocates for ourselves. I want to thank Project Lyme and Davia specifically, who works on communications at Project Lyme. None of the opinions or statements made tonight were verified or reflect the opinions of Project Lyme, the organization themselves. They're all reflective of the individuals, myself included, who said them. But we are so appreciative for Project Lyme's help with putting on these kinds of events that inform patients and that help, again, patients be better advocates for themselves. Everybody that registered for the webinar tonight will receive a recorded version to the email that you registered under, and you'll also receive a packet of resources that the panelists here tonight helped me put together for you all, including, as Jen just mentioned, a draft letter that you can personalize and send to your congressman or representative if you feel like you want to take steps towards beginning your own advocacy journey. So on that note, I will wish you all good evening. Thank you again, and have a good night.
Thank you, Sabi.
Thank you.
you.